Outsourcing feels easier for a reason. If you're running a medical group today and you're already operating at capacity, you're short on time, short on staff, and constantly making trade offs just to keep the clinic moving. So when someone shows up and says, "We'll handle this for you," that offer lands. No hiring, no training, no workflow design, no internal politics. Somebody else knows the rules. Someone else worries about compliance. Someone else is responsible if something breaks. That kind of relief is real. And showing outsourcing in that moment isn't lazy or uninformed, it's practical. What doesn't get explained up front is that outsourcing doesn't just remove work, it removes ownership. And that distinction matters more than most practices realize. When care is delivered outside of your clinic, you no longer fully control how that care happens. You don't control the cadence of outreach, the tone of the patient communication, or how aggressively issues are escalated. You don't control who is making the judgment calls in gray areas. You don't control how clinical information flows back into your physician's day to day decision making. And none of that's malicious, it's structural. And structure creates ceilings. Clinically, outsourced care has to be standardized. Vendors are responsible for many practices at once, so they rely on protocols that are safe, repeatable, and defensible. That means templated messaging, predefined thresholds, and conservative escalation rules. Those systems work, but they don't adapt well to individual physician preferences or nuanced patient populations. Over time, that nuance gets delayed. A borderline issue that an internal team might flag, it gets pushed to the next scheduled review. A patient who would benefit from a slightly different approach gets handled by the book. Outcomes don't crash, they just flatten. There's also a subtle shift in physician engagement. When care happens somewhere else, physicians stop seeing it as an extension of their practice. They don't see the micro decisions that are being made. They don't see the patterns emerging in real time. Those feedback loops weaken, and it's not because doctors don't care. It's because the care is no longer happening within their ecosystem, and when clinical ownership erodes, outcomes just stop improving. Operationally, outsourcing caps learning velocity. Internal teams get better simply by doing the work. They learn which messages patients respond to, which data points actually matter, and where friction shows up in real life. Those lessons compound month over month. Outsourced teams can't customize deeply for a single clinic without breaking their model. Any improvement has to scale across all their clients, which means your practice stops benefiting from its own experience. You plateau operationally even if volume grows. Handoffs also introduce latency. Every time data moves from your EHR to a vendor platform, from their staff to your staff, or from their protocol back to your physicians, time is lost. That delay sounds small, but in chronic care it matters. Momentum is part of medicine. When response times slow, patients disengage. And when a patient disengages, outcomes suffer quietly. Financially, this shows up in ways that aren't always obvious at first. Revenue may be acceptable, even good, but margins flatten. Vendors have to cover staffing, software, compliance, and profit before value reaches your practice. Internal programs, they behave differently. They often feel heavier early because you're investing in people and process, but over time, efficiency improves and margins expand. Outsource models rarely do that. They stabilize margins at best, but that's the financial ceiling as well. One of the most common things that practices say is, "We'll outsource now and then we'll bring it in house later." In practice, later never arrives. Internal workflows never get built, staff never develops that muscle memory, and leadership never really truly sees the demand for between visit care. Outsourcing becomes permanent Not because it's ideal, but because it's familiar. And to be clear, outsourcing absolutely has a place. It makes sense for smaller panels, for patients with unstable staffing, or when leadership bandwidth is genuinely limited. It can be a smart bridge. The mistake is treating it as a destination instead of a temporary solution. The highest performing clinics eventually shift the question they're asking. Instead of which vendors should we use, they ask what care should live inside our practice, even if technology supports it. That shift changes everything. Staffing becomes intentional. Physicians stay clinically connected. Learning compounds. Outcomes and margins improve together, not overnight, but steadily. Outsourcing doesn't fail because it's wrong. It fails because it's designed for convenience, not ownership. And ownership is what compounds over time.